or good morning, depending on where you're joining us from. My name is CADTH. I'm part of the Performance Analytics team here at Canada Health Infoway. Thank you to all of you for joining our webinar today, where we're talking about all things related to virtual care evaluations. We do have simultaneous interpretation available for this event. If you'd like to listen to this presentation in French, you can click Interpretation at the bottom of your Zoom toolbar and select the French channel and then mute original audio. If you're listening in English, you don't need to do anything. So we've got a great agenda for today's webinar. Following a few short introductory remarks from me, we're going to jump into two great presentations that we've got lined up. First, we're going to hear from CADTH on a recently conducted environmental scan of evaluations in virtual care. Following that, we will be hearing from some new research out of Queen's University that looks at the experience of virtual care experience for allied health providers. As usual, we will save the Q&A for the end of at the end of the presentations. However, I want to encourage you to submit any questions or comments you have throughout the webinar using the chat function, and I'll just moderate them at the end. So jumping into our first agenda item, just a quick welcome to those that are new. Thank you for joining us, and those that are returning, thank you for continuing to join us. And just briefly for the new attendees, these webinars are a platform for those of us that are conducting evaluation in the digital health space to convene and share best practices, our evaluation methods, results, and other insights that we can learn from each other. And if you're not already on our mailing list, I encourage you to get on our mailing list so you can stay up to date on future webinars. And as always, we will be posting the material from today's webinar on our website, so stay tuned for that. So our first presenters today, I'm really excited to introduce Daphne Huey and Chris Campbell from CADTH. Daphne is a clinical research officer at the Canadian Agency for Drugs and Technologies in Health, CADTH. Daphne has a Master's of Science in Physiology and Pharmacology from the University of Western Ontario. At CADTH, she's involved with the systematic retrieval and appraisal of scientific research to assess the utility and impact of health technologies such as pharmaceuticals and medical devices to support practice and policy decisions with a pan-Canadian perspective. Joining her is Chris Campbell, Director of Rapid Response and Program Development at CADTH. Chris is responsible for rapid reviews, horizon scanning, and topic identification within the Medical Devices and Clinical Interventions Directorate, and oversees work related to digital health. So I'll pass it over to you, Daphne and Chris.
Great, thank you very much, CADTH, and thanks to Infoway for hosting us today. As mentioned, we'll be talking about some work that we have done looking at evaluations and frameworks for evaluation of virtual care in the primary care setting. And so our plan for today is I'm going to give just a bit of background and context, who we are, why we took on this work, and then I'll hand it off to Daphne to speak a bit more about the findings of our environmental scan. Next slide, please. So first and foremost, just by way of disclosure, both Daphne and I are employees of CADTH, the Canadian Agency for Drugs and Technologies in Health. But we have no financial conflicts to declare with respect to this work. CADTH itself is funded by the federal, provincial, and territorial ministries of health, with the exception of the province of Quebec. And we do accept application fees from industry for 3 programs: the Common Drug Review, the Pan-Canadian Oncology Drug Review, and our Scientific Advice Program. Next slide, please. So what is CADTH? So we are an independent, not-for-profit health technology assessment organization, or HTA organization, and we're responsible for providing Canadian healthcare decision makers with evidence about the optimal use of drugs and medical devices. And if you'd like to know more about CADTH and the work that we do have an information session planned for April 5th that is open for registration. And so what is HTA? What is HTA? HTA is a process that determines the value of health technologies by using explicit methods in a multidisciplinary process. And so what HTA attempts to do is look at the intended and unintended consequences of technologies. And at CADTH, that multidisciplinary process includes looking at things like the clinical effectiveness of technology, cost effectiveness, patient and caregiver experience, implementation or organizational considerations, ethical considerations, legal considerations, and others. Next slide, please. So virtual care, as we all know, sort of exploded about 2 years ago with the onset of the pandemic, and it's provided some particular challenges for health technology assessment. So for one thing, we saw a shift in the types of questions that we were seeing, moving from, for example, from specific interventions and indications to more broad technology questions. So for example, prior to the pandemic, we had done some virtual care work on internet-delivered cognitive behavioral therapy, and that was focused on the use of that technology for depression and anxiety. But now the questions that we're seeing are sort of more open questions, such as who is virtual care appropriate for, what patients should be receiving virtual care, and things of that nature. So that really has opened those questions up and made it a bit more challenging for health technology assessment. It's also brought a heightened emphasis on that multidisciplinary analysis. So far in the past, we would be focused more on clinical and cost effectiveness. But as I mentioned, we now have additional components to our health technology assessments. And even the way that we focus on some of those components has shifted a little bit with virtual care. So for example, some recent work we did on remote monitoring for chronic cardiac conditions, we didn't do a formal assessment of clinical effectiveness because this was known, but we did something called a realist review, which was a first for CADTH, which is really exploring the context under which remote monitoring would be effective and for whom it would be effective. And the recommendations produced for that work also included an increased emphasis on things like data governance or digital health equity, which may not have been involved in health technology assessments we had done in the past. The rapid adoption of virtual care also precluded HTA. And so typically, our process would be to conduct an evaluation of a technology to inform its adoption, and then continue to look at the value that technology brings throughout the technology lifecycle. But as we all experienced in March of 2020, there was a rapid shift to an online world. And so that type of pre-implementation assessment wasn't possible. And so that kind of assessment that we might have done would have been based on things like randomized controlled trials or other experimental study designs. But now that rapid shift has precluded doing that type of research potentially, and we're now looking at different types of data to inform decisions. And so the wide adoption of virtual care has provided an opportunity to use other data sources, things like real-world evidence, to collect data in real time to inform those decisions about what to continue and what maybe to discontinue. And so that leads to questions about what data needs to be collected and what should that data look like to inform those types of decisions. And so these are challenges that we're working through currently. Next slide, please. But the good thing for us is that we're not alone. So there are many groups that are working on similar problems and many groups that have done evaluations of virtual care, each using their own methodology. And so what our work attempted to do was to look at that landscape, what has been published in terms of how evaluations should be conducted, what evaluations have been conducted, and what were the outcomes of those evaluations. And the reason we did this work is to help inform our own thinking about how to evaluate virtual care, but it was also done to support collaborative work with the Center for Digital Health Evaluation at Women's College Hospital, with CADTH and with Canada Health Infoway, to help sort of inform other decisions about how to evaluate virtual care and give us all sort of a common ground to start with. And so with that, I'm going to turn it over to Daphne, and Daphne is going to walk us through in more detail what the findings of that environmental scan were.
Great, thanks, Chris. Just want to double check that everyone can hear me. Okay, I'm gonna just go ahead, but yes, thank you, Chris. So I'll now present the context, methodology, main findings, and conclusions of the scan. Next slide, please. So to provide some context, the COVID-19 pandemic has served as a rapid catalyst for the uptake of virtual care around the world. However, this rapid adoption has highlighted various challenges and considerations associated with virtual care. This resulted in the need for continuous evaluation to inform strategies and policies and to develop standards for the effective implementation of virtual care. So next slide, please. So just to provide a Canadian perspective, this slide highlights data from the Canadian Institute for Health Information, and this is data based on the period from March 2020 to March 2021. So as you can see here, the use of virtual care in family medicine was lower in December of 2020. And at this point, this is when COVID-19 monthly community cases were highest in Canada compared to April of 2020 during early or initial stages of virtual care implementation. So as we can see here, adoption of virtual care in family practice was highest in British Columbia and lowest in Alberta during both these time periods. Okay, next slide, please. So the actual written report details the definitions that guided the scan, but I just wanted to highlight here that the virtual care definition that we followed for the scan was adopted from the Canadian Medical Association's Virtual Care Task Force, and that virtual visits considered in this scan were both synchronous and asynchronous. So synchronous communication included telephone or video conferencing, and asynchronous communication included modes such as text messaging. Okay, next slide, please. So the main objectives of the scan were to identify and summarize key information from methods, standards, and guidelines, which we'll now refer to as evaluation guidance documents for evaluating virtual care, and also published evaluations of virtual care. So the key information consisted of methodologies, inputs, outcomes, measures of value, and considerations of evaluating virtual care. Okay, next slide, thanks. So this environmental scan was informed by one literature search that was conducted from January 1st, 2019 to September 1st, 2021. And we chose to focus on virtual care between physicians and health teams and patients, both adult and pediatric patients in primary care settings. Although evaluation guidance documents were still included if they discussed specialty care. And there is no specification on the country of focus regarding virtual care. And as a result, the informing evidence came from Canada and other countries. Just wanted to highlight that assessments of digital health interventions, such as e-prescribing and devices such as remote monitoring, were considered out of scope for this scan. Next slide, please. Okay, so in total, we identified 7 evaluation guidance documents to inform evaluations from the perspective of Canada, United States, United Kingdom, Australia, and Pan America. So in particular, the Canadian guidance came from the Heart and Stroke Foundation, and as well the Canadian Association of Cardiovascular Prevention and Rehabilitation. So accordingly, we focused on stroke management and cardiovascular prevention and rehabilitation. And to highlight, the Pan American document was from the Pan American Health Organization, with representation mostly from Colombia, Mexico, and Peru, but there is no representation from Canada. Okay, next slide, please. So now I'll just highlight the themes or guidance that were touched upon by most or all of the guidance documents. So firstly, it was advised that outcomes should be feasible and meaningful. So in other words, the measurement must be possible given that limitations such as time, resourcing, and the capacity and skills of providers allows for this. And also the outcomes should be reflective of goals, targets, needs, and priorities of stakeholders, such as the patients, the healthcare providers, and healthcare systems at the community, provincial, or national level. And next, cost or saving outcomes are not limited to monetary and financial measures, but are also related to time. And specific to economic outcomes, determining the perspective is important as it defines which inputs, such as costs, or outputs, such as benefits or effects, are included in the analysis and how outcomes are interpreted. Next slide, please. Okay, so among the guidance documents, some key planning decisions were also highlighted. So the first one was scope, and this essentially suggested that one must ensure that the evaluation is comprehensive, but not complex and not resource intensive. And next, the comparator should be relevant in real-world clinical practice. And further, the timing of the evaluation needs to be thought through regarding potential biases that may arise from conducting an evaluation in a particularly seasonal or notable period. And by this, I mean, for instance, performing an evaluation when many healthcare providers go on vacation, or there's more or less changes to funding due to grants or change in policy. And if the timing of the evaluation is not long-term, then it should be specific to a particular implementation stage of virtual care. So for instance, to reflect an earlier stage, such as a pilot project. So in relation to this, some outcomes may be more important at specific times. For instance, if it's an early evaluation, then outcomes could measure the alignment with initial objectives and goals and targets. If it's a more of a mid-stage evaluation, then outcomes could measure optimization, versus if it's a more established stage, then outcomes could measure the social and economic impact. So the last consideration here is duration. So similar to timing, the duration is important to consider, as it should facilitate adequate and appropriate measurement, with guidance advising to focus both on individual sessions and the entire program. Okay, next slide. Okay, also, I apologize for the appearance. We submitted the slides to combine into one deck, so it probably some formatting issues arose. So I'll try my best to really clearly articulate all the text on the slides. So this slide here I put together summarizes the recommended outcomes from all the documents and are categorized based on similar factors and associated examples. So the first measurement outcome category is effectiveness and quality of clinical care, including safety. So some examples of these measures would be to assess the frequency of positive and negative events. Positive events being those such as successful consultations, and then negative events being those such as adverse events. The next category is time and travel. So for instance, this could include measuring wait times and the specific travel time and travel distance. Okay, and then the next category was financial and operational impact. So this includes examples such as cost per episode of care, and then perhaps expenses specific to virtual care, such as the technology setup and maintenance costs. And next we have participation outcomes. So for instance, the number and the rate of attendance or cancellations or no-shows. Next, we have healthcare utilization, which could be measured, for instance, as the need for follow-up in-person or virtual appointments related to the initial virtual consults, subsequent hospital admissions, and emergency department visits. Next, we have technology experience, including feasibility. So this could include user convenience and technical difficulties. And the next category was user satisfaction. So a measure of this could be, for instance, if the provider is willing to adopt virtual care in the future, and if the patient is willing to participate in future sessions with virtual care. And the last category we have are the barriers and facilitators or health equity measures. And this could be measured through a delay in care due to access barriers, such as limitations to accessing technology, or for instance, geographical limitations, especially for those who live in rural or medically underserved areas. Okay, thank you. So next slide. Okay, so similar to the previous slide, this one summarizes now the recommended considerations instead of the actual outcomes that were touched upon by all the guidance documents. So the first consideration category were society aspects, which include economic, legal, political, and socio-cultural factors. And then next, we have considerations such as the type of care. So for instance, is this care that's implemented in primary care versus specialized care, or is it implemented in a hospital setting versus private practice or in a rehab facility? And then the next measurement consideration was measurement. So what are you sort of measuring? Like, is that effectiveness or efficacy, the accessibility or technology usability, or the patient or provider experience? And the next group of considerations are the stakeholders. So most importantly, we have the patients and their caregivers and their family members. But we also have, of course, associations of health professionals and research groups. And at the broader society level, we have regulators and policy decision makers, plus the community as a whole. And then lastly, we have the barriers and facilitators for health equity measures. And similar to before, again, these would touch upon access to technology, feasibility of implementation, and then financial or time costs. Okay, next slide. Thank you. Okay, so as mentioned, the second part we focused on were actual evaluations that were published, and we identified 11 published virtual care evaluations, and these were conducted in primary care across United States, United Kingdom, and Australia. And these covered general primary care, antibiotic prescriptions, mental health services, and drug addiction services. So this evidence consisted of both primary studies, mostly non-randomized comparative studies, and systematic reviews. And I just want to highlight that all the non-randomized comparative studies were conducted retrospectively or prospectively and included data that was specific to a period of COVID-19. Okay, next slide, please. Okay, so in the interest of time, I'll just discuss the main findings and considerations that we came across from these identified evaluations. So the first focus is on the economic outcomes, and the main finding was that virtual care may be more cost effective compared to in-person care. So it was found that virtual care reduces the cost per episode and patient expenses, such as those related to travel and parking costs. However, one must consider that virtual care may actually increase the number of individuals treated, which would then increase overall healthcare spending. Okay, next slide, please. Okay, so next were the healthcare utilization outcomes. So from these evaluations, it was found that virtual care reduces the duration of the appointment and may be more time efficient compared to in-person care. However, it wasn't clear from the included evidence if virtual care reduces the use of medical resources and the need for follow-up appointments, hospital admissions, and emergency department visits compared to in-person care. Okay, next slide, please. Thanks. Okay, so next were the participation outcomes. So for this, the evidence was mixed for the comparisons to in-person care. So for instance, some of the evidence reported that virtual care reduced attendance, whereas other evidence found that it improved attendance. But a few considerations for participation outcomes include, firstly, that some indications for a health consultation require one appointment, whereas others require multiple appointments. So that should be distinguished when evaluating these types of consultations. But also, I don't have this highlighted on the slide, but age is a very important consideration for participation. For instance, those that tend to be younger tend to be more well-versed with technology. Therefore, they may have better participation with virtual care appointments, whereas older adults who may not be as well-versed with technology may have difficulty with participating in virtual care appointments. Okay, next slide, please. Okay, so the next set of outcomes that were focused on from these identified evaluations were the clinical outcomes, and these were investigated in 3 evaluations among various health diseases or health contexts. And similarly, it was found that this evidence was mixed when compared to in-person care. So for instance, some studies found that there was clinical improvements when virtual care was used versus other evidence found that it actually didn't really elicit much of an effect on the clinical outcomes when compared to in-person care. So the main consideration when assessing clinical outcomes is mostly that these measures need to be very specific and relevant to a health context or disease. And even within these health contexts and diseases, it should be specific to perhaps symptom or disease severity and the stage of a disease. Okay, next slide, thanks. So similarly here for prescribing outcomes, the evidence was mixed when there were evaluations compared to in-person care. So similar to what we saw before, sometimes it's demonstrated virtual care improved appropriateness of prescribing versus virtual care could have elicited no difference when compared to in-person care. Okay, so thank you. So this is my conclusion slide here. So overall, the evidence found that virtual care may not be suitable for all patients. So for instance, in-person may be preferred for those who require physical examinations, but then virtual care may be preferred by those who require a series of appointments and would have to go attend many appointments or experience limitations to travel. So reasons for travel limitations could be related to work, finances, the actual distance, disabilities of the patient and or the caregiver themselves, and need for assistance with other personal care, such as watching other dependents, such as children. And then the findings from the identified evaluations were that overall, the findings lack certainty, are limited in generalizability, and are generally inconclusive due to the mixed findings. And then from the guidance documents, the main conclusions were that evaluations should be systematic, performed regularly or periodically, and reflect the implementation stage, such as an early pilot stage or a later established stage. And that there should be an assessment of individual sessions and the overall implementation of virtual care. And most of that evaluation should be specific as possible to be informative. So in other words, combinations of healthcare types or services and health contexts or diseases should reflect real world. So for instance, combining primary care and the surgical specialty type amongst pediatric and geriatric patients may not be the most informative type of evaluation. Okay, next slide, please. Okay, so yes, this one I'll make sure to really read out the text. So this slide here basically just provides a few considerations for future work and policy based on the limitations identified from the evidence that informed the scan. So firstly, there was a need for higher quality virtual care evaluations that have reduced confounding and are greater in relevance. So specifically, there's a need for more similar comparison groups and characteristics such as age and medical history and socioeconomic status, as these are considerable confounders. And additionally, evaluations should be separated for healthcare types and services, for example, separating out surgical and non-surgical specialties or hospital care and private practice. And further, there was also a considerable limitation of the included evaluations, and mostly that they combined different virtual care modalities. So for instance, oftentimes they combined the evaluations of text messaging, video conferencing, and telephone appointments together. But it's important to distinguish because each of these types of modalities have their own technical considerations, benefits, and limitations. And next, there's a need for future evaluations to improve generalizability to other stages of the pandemic or in a more hopeful scenario outside of the context of COVID-19. So much of the included evidence that we came across was restricted to the early waves of COVID-19, which is a situation with distinct factors that limit the generalizability. So namely, the lack of preparedness for virtual care. So for instance, a lot of providers at this time may not have had much experience or were not set up to use video conferencing for their appointments. And there's also a limitation primarily for those of the lower socioeconomic status with access to technology. So at this time, libraries and schools were closed, as well as dine-in fast food restaurants such as McDonald's or Tim Hortons or other places that provide free Wi-Fi. So overall, there was less public access to devices and Wi-Fi. And generally, this was just a time of poor mental health and higher stress for most individuals, as there were new increased priorities such as helping young children with virtual school and those who require personal support, such as those living with chronic diseases, perhaps had less support from caregivers and support workers because visits had to be less to reduce the spread of COVID-19. So just those own considerations. And then the last point here, just wanted to highlight that with virtual care, there you can implement it across jurisdictions. So there could be considerations with billing, so that complicates how you bill the provider. Oh, and sorry, I missed one point here about filling evidence gaps for vulnerable populations. So in particular, there were 2 vulnerable populations with considerable policy relevance in Canada, and these were highlighted to be older adults and Indigenous peoples. So as I briefly alluded to before, older adults experience particular challenges with accessing technology due to their perhaps lack of experience, and then just it requires a greater dependence on caregivers. And then Indigenous peoples already face barriers to equitable access to healthcare due to historical and ongoing effects of colonialism. So given that their communities and their reserves are generally more isolated and remote, specific evidence and the perspective of Indigenous peoples is very important. So overall, there's a greater need for Canadian-specific evidence, especially frameworks. Okay, next slide, please. Okay, so this is just a conclusion slide. So as there's a need for future evidence, there's also potential to update this environmental scan. So to close, additional evaluations of higher quality evidence are needed for more relevant, informative comparisons with in-person care to facilitate decision and policymaking regarding evaluations of virtual care in Canada. Okay, so that concludes my presentation. Yes, thank you for listening. We can probably make the slides available because I know there's some presentation viewing issues with those, but I'll pass it on to the Queen's team now for their presentation.
Thank you, Daphne. I apologize to everyone for the challenges with the slides, but we will make sure that they are reformatted, and when we upload them that they are accessible to everybody. Thank you again, Chris and Daphne, for summarizing an incredible amount of work in a fairly short amount of time. So we're gonna turn it over to our researchers from Queen's University. I want to welcome Dr. Ramana Apparetti. He's a stroke neurologist and assistant professor of neurology in the Department of Medicine at Queen's University. He has a keen interest in implementing virtual care solutions to improve access to specialist care. He has an active research program in virtual care, which is funded by multiple external and internal funding organizations. His research program focuses on implementing virtual care, evaluating virtual care services, and understanding the facilitators and barriers in virtual care implementation. A significant area of his current research is conducting patient-oriented research in virtual care to understand better and address the challenges and facilitators of virtual care access from a patient perspective. Joining him is Dr. Heather Braun. Dr. Heather Braun completed her PhD in Assessment and Cognition at Queen's Faculty of Education. She's a health education researcher and consultant with the Office of Professional Development and Educational Scholarship in the Faculty of Health Sciences at Queen's University. Additionally, she holds assistant professor adjunct appointments with Queen's School of Medicine and Queen's Faculty of Education, where she teaches curriculum, program evaluation, knowledge translation, and cognition courses. She has experience with conducting quantitative, qualitative, and mixed methods research in addition to program evaluation. I'll turn it over to both of you now.
Sorry about that. Good afternoon, everyone. My name is Ramana Apparetti. I'm an assistant professor of neurology at Queen's. I'll be joined with presenting today's results with Dr. Heather Braun, who is the co-investigator on this study. So next slide, please. A few disclosures. I do have some internal and external peer-reviewed funding for my research program. Don't have any other financial conflicts of interest. Next slide, please. Yeah, a little bit of background. This is an often repeated message during the COVID era. As you all know, the COVID has resulted in a rapid and widespread adoption of virtual care in Canada by various healthcare providers. mostly by physicians, but a significant proportion of non-physician healthcare providers also had to make the transition to virtual care and use various modalities to continue to provide their own healthcare. And these included OTs, physical therapists, psychologists, social workers across the spectrum. Next slide, please. And just a little bit emphasis on the role of allied health, that they play a very crucial role across the continuum of the healthcare, both from inpatient care to ambulatory care to transitions of care to even end-of-life care and palliative care across the spectrum. And they really play a very crucial role in supporting patients as they in their homes and providing rehabilitation and helping support remote healthcare and self-management and trying to reduce the length of stay during their hospital admission, and also prevent any readmissions to the hospital and support the prevention of ill health. Next slide, please. So as part of the studies, we try to look at what is the proportion of non-physician healthcare providers within our healthcare system, and CADTH keeps track of this data, and they have a multiple categories of non-physician healthcare providers, and they have over 30 groups of health professionals that are categorized based on their profession and discipline. And this information is provided at on their website, and the hyperlinks to that are available at the bottom of the slides. Next slide, please. So for the purposes of this study, we wanted to basically identify the experience of non-physician healthcare providers with transition to virtual care. And given our location working at a university healthcare setting, we wanted to explore the experience of a certain group of non-physician healthcare providers, which included dietitians, occupational therapists, physical therapists, and psychologists, and respiratory therapists, and social workers, and speech pathologists. If you look at the numbers, 23% of healthcare professionals in Canada belong to this category, and this excludes the nurses and the physicians. So it's a sizable number of our healthcare workforce. Next slide, please. And so we went around, if you look at what is known about the virtual care services provided by non-physician providers or allied health, there's actually an information gap noted by CADTH that virtual care services by other healthcare professionals is a huge information gap. Whereas we have very good and robust information on the volume of virtual care services provided by physicians, but for the other healthcare providers, we don't have the data. We also know that COVID has had a significant negative impact on mental health of healthcare providers across the spectrum, and most of the brunt has been borne by non-physician healthcare providers. So next slide, please. So with this sort of a background, non-physician healthcare providers or allied health constituting a good proportion of the healthcare workforce, and not having information about what their volumes are and what the workload that they have taken up during the COVID. And the current research is mainly focused on patients and physician experience with virtual care. However, at the time when we conceived the study, there was not a lot published around what is the experience of allied health providers in transitioning to virtual care. And so that was the reason why we embarked on the study 1.5 years back. And now we sort of completed the study, and I'll now pass it on to Dr. Braun to discuss the methods and the results and the implications of our findings.
Great, thank you very much. Okay, so for this study, we used a qualitative phenomenological approach, as we really wanted to understand the lived experiences of our allied health providers, especially around when they first started transitioning their in-person care to virtual. So we were able to recruit 40 allied health providers, either through viewing a study poster that we circulated, and also a combination with snowball sampling. So we conducted semi-structured interviews once they agreed to participate. Most of these interviews were done by Zoom, phone for just a couple, but obviously Zoom was preferred so that we could have more interaction. And this was done between February and July of 2021. These interviews were audio recorded and transcribed verbatim. And then our interview guide consisted of 5 main sections. The first was a background, which really just helped us to learn the years of experience that the providers have and a little bit more about their role. And then we moved into talking about the quality of care that was delivered virtually compared to in person. And then we asked them about different resources and training that they'd had and what they would like to see in the future. And then we really focused on healthcare system efficiency and how virtual care may impact that. And a nice robust discussion at the end focused on health equity and access for patients. Next slide, please. So in terms of our participants, our providers were from outpatient clinics in the hospital or community, and also home care setting within Kingston, Ontario. So we were able to recruit a nice diverse group consisting of nurse practitioners, occupational therapists, physiotherapists, psychologists, registered dietitians, social workers, and speech language pathologists. And it's important to note that across the 40 participants, they represented a variety of clinical domains. So some worked with the pediatric population, others worked in oncology. There was a large group focused on rehabilitation therapy, and then a large group also focused on chronic conditions, and some also focused on supporting mental health. Next slide, please. Thank you. So the completed interview transcripts were uploaded into NVivo version 12, and we analyzed them using a thematic approach. And we also wanted to ensure that we had an appropriate level of intercoder reliability. So for this process, we had another researcher who coded a sample of the data independently, and then they met with us and we went through line by line and compared. There were only instances, 7% of that selected coding sample where we disagreed, and during those instances of disagreement, we just worked through them and decided on how it should be coded, and this process really resulted in a consensus-built code book that was then used for the remainder of the coding. Next slide, please. Oh, perfect, thank you. So now we'll get into the results, and this slide just presents an overview of the themes. So we had 4 themes that were identified, and then for the next few slides, we'll give a quick overview of each theme, followed by some sample quotations. Next slide, please. So for theme 1, this was focused on the quality of care. So generally, virtual care was reported as less stressful, more comfortable for patients, and ultimately more patient-centered. In terms of what was the same between in-person and virtual care, our providers suggested that the education they provided, generally the care, unless they required a physical exam, for example, the patient-provider report, and most of their information gathering was all quite similar between in-person and virtual. Of course, this wasn't without challenges, so that included the level of engagement. This was of particular interest during education sessions, for example, group sessions. So some of our providers weren't quite as sure if the patients were as engaged virtually. Perhaps they were doing other things during the group sessions. Also, a number of providers identified concerns around not having visual cues, although it was encouraging to see that they had developed some strategies of asking specific questions, for example, to try and get at some of those visual cues that they were missing. And of course, there were issues with technology as well. Although ultimately virtual care was easier for some providers, it definitely depended upon their scope. So for example, physiotherapists in our study reported challenges with providing their care virtually. And generally, the virtual care was deemed to align quite well with professional standards across the colleges and governing bodies. And most of the providers were quite satisfied actually with the quality of care that they were providing virtually. Next slide, please. So here's a couple of quotations. The first being, I think with time, we can still develop the same level of rapport as we do in person, and that was shared by an occupational therapist. And the next, in the group setting, the background noise interference, and also patients who are distracted, especially in the group setting, when the focus is not entirely on them. I get the sense that they are sometimes doing something else on their computer, or they can easily slip away. They can log off and think they're going unnoticed, but it is noticeable. And that was shared by a dietitian. Next slide, please. So for the second theme, focused on resources and training, the vast majority of our providers shared that they had minimal to no training in how to conduct patient care virtually. And even though they had self-taught themselves, they would still appreciate training even now after a year and a half or 2 years. They were quick to share some desired topics, which included facilitation strategies. This would be particularly useful for group sessions or education sessions. Generally, they just wanted to know what the best practices were around providing virtual care. They also wanted additional information around confidentiality and privacy. So although they had some information from their associations, they wanted some more standardization around that and just to ensure that they were in compliance. They also identified that it would be helpful to know how to troubleshoot technology, both on their end, but also if their patients were struggling. Generally, most participants reported that virtual care training should be mandatory for all providers, as they felt that it would be here to stay in some form. Helpful resources for them included access to IT support and also their colleagues. And many providers shared that they would like more support around scheduling and setting up virtual encounters to enhance efficiency. Next slide, please. So a couple quotes here. The first being, it has pretty much been us trying to figure it out. So we were basically told from the beginning that we're going to start shifting into telephone visits. And it has pretty much been a collaborative effort from all sides of the healthcare team. So everyone has had to figure out how to fit it into their routine and how to fit it into the way that work and what works for them. And that was shared by a nurse. And the next, I think having the ongoing support with someone you keep reaching out to and say, okay, now I have run into this, what do I do? I think that is most effective, and that was shared by a psychologist. Next slide, please. So the third theme focused on healthcare system efficiency. Generally, our findings suggest that it does increase general efficiency across the system, and most of our providers suggested that it was a proactive rather than a reactive approach. Other benefits included faster referrals, a wider reach across the patient population, increased uptake of patients, not having to travel, especially for our community providers, improved attendance and fewer cancellations, and sometimes less time. Providers did reiterate the need, though, to have in-person care as an option, and some community providers reported the benefits of using virtual encounters to gather information, and then they would follow up with an in-person. Next slide, please. Okay, so I'll just read one quote for the time. So, to me, I can do 7 intakes in my shift, which is a lot, as opposed to only being able to do 2 face-to-face, and that was shared by a nurse. Next slide, please. Okay, the final theme focused on health equity and access. So our providers did have many concerns regarding inequities across the system, but they generally reported that virtual care helped to make patient care more equitable, so long as the patients had access to the technology. So they felt that it reduced barriers related to finance, transportation, and geography. And a few recommendations that they provided included having access to private space and technology, and also learning from the education system where they had to provide technology, for example, to their students in need. Next slide, please. Okay, so I'll just read the last quote. Leveling the playing field, there are issues around not having the finances or transportation. So that makes it a lot easier for some families. And so it makes it more equitable in that sense. And that was by a psychologist. Thanks. So this study, as we know, or to our knowledge, is one of the largest qualitative studies conducted to understand the experiences with virtual care from allied health providers. And our findings highlight the need to support providers further, specific with training on how to actually conduct virtual encounters. And further, we should think about leveraging some of the advantages, such as improving efficiency of healthcare delivery, potentially reducing provider burnout, and increasing capacity. Next slide, please. So we'll just share a couple of knowledge translation that our group's involved in. So we're actually using this research in conjunction with patient identified priorities to develop an educational module. And we're happy to report that it's hopefully going to launch in May 2022. It will be open access. It will be accredited by the Royal College and College of Family Physicians. And it will hopefully share some of our great best practices and is evidence-based. And then we also have a virtual care access toolkit that's available there. And it's important to note that this was developed by patients for patients. So we encourage you to look out for those resources. Next slide, please. Okay, thank you so much. We appreciate your time.
Thank you, Dr. Apparetti and Dr. Braun. That was, I appreciated how you kind of whisked through it, Heather, but I would love to maybe bring back all of our panelists. We probably have just a few minutes for some questions. So if we can, and if you do have any questions, feel free to submit it using the Q&A feature. And again, apologies about the CADTH presentation not being able to see some of the content. We will be uploading the full content following the webinar. Maybe I'll start with a question to Chris or Daphne, but some questions that we've gotten, and I'll just kind of summarize it. Can you maybe just comment on the timeline, when the study, why it was limited to the 2019 to 21, and if the literature you consulted, it was just limited to English, and maybe just comment on that.
Sure, yeah, I can answer that quickly. So the literature, while we looked for international experience, we did limit to English language publications. Mostly that's like a pragmatic decision. Non-English would require additional translation and those types of things. And I think there is evidence that suggests that at least for systematic reviews, limiting to English doesn't significantly alter the findings. So I would do recognize that that might not be the case for evaluations of virtual care. And then the question in terms of the time frame. So we were really focused on sort of the COVID experience and trying to capture evidence from that context, so that rapid, almost universal shift to virtual care. And there was some concern, as we were planning this work, that reaching further back may not be reflective of that, or we may be capturing virtual care that isn't necessarily reflective of how it's being conducted currently, or may not be in the future. So, for example, the Ontario telehealth, there may be literature on that, but I don't know that that's reflective of the current experience of widespread virtual primary care.
Thank you. And just a follow-up question that we got. Can you just comment on if this work is available, accessible for those that are interested? Sorry, Chris or Daphne.
Sorry, the question is whether it's published and available. Yes, so the environmental scan is published on the CADTH website, and I believe in our Journal of Health Technologies CADTH publication, so it should be findable in both.
Great, thank you. Maybe I'll just turn it over to Dr. Apparetti and Dr. Braun for a question. Some comments here. This is really fantastic, helpful work, and a question about what are the challenges maybe in the evaluation, even just conducting an evaluation in the allied health population. You've got a mix, different, mix of allied health professionals, maybe just from like a methodology perspective or sampling. Like, do you want to share any insights that you got from even just developing instruments that would, capture the breadth of the different types of services they provide, right?
Yeah, I'll take a part of that question, Spirita. So from a sampling perspective, I think there are some challenges and some issues that we need to acknowledge because we sample and the experience of this heterogeneous group is heavily influenced by the technology and the platforms that they have access to. For example, if the healthcare providers that are based at Kingston may have access to a certain platform that may not be as easy to use for both the providers and for the patients, versus some other healthcare settings where they have access to a more sophisticated EMR with the integration of other video conferencing abilities like Zoom, which makes the whole experience so seamless and easy for everyone. So so our experience and our results, I would say, are not totally generalizable to all the settings, but to most of the settings that do not have a robust EMR or a virtual care solutions. For experience from actually talking to them, Heather has been the lead on this, so I'll let her answer any thoughts that she has.
Thanks. The only thing I'll add is I think this is one reason why a qualitative approach is really helpful here, because in our interviews, we were able to maintain a semi-structured approach. So I would often add in questions based upon the role and based upon some of their earlier comments. So that was a really useful aspect of that measure, that if we were taking more of a quantitative standardized approach, we might not have that flexibility.
Maybe just a follow-up question to the research on where, how will you evolve this research, or is this research available? For those that are interested in having access to these findings?
So we're in the process of publishing this paper, but we're also in the process of doing a pan-Canadian study right now with allied health providers across Canada. So we acknowledge, one limitation was this was centered in Kingston. So it's really interesting to hear the differences in experiences from province to province. So I think that's a nice next step, and we look forward to hopefully pushing that into publications and also modules.
Great. I want to thank all of you for all of our presenters for joining today, for the insightful research that you've shared, the methodologies that you've shared, and a big thank you to all of you that have attended as well. Please continue to stay engaged with us and participate in future webinars. And I'm really glad I had the opportunity to connect with all of you and hear about all of this exciting research, and hope to catch you on a future webinar. Thank you.